It is a huge honor for me today to be podcast interviewing Eric Schuetz, who's making me look so bald today with your hair. I'm extra jealous today looking at that hair. I love your name, Schuetz. It's got a Z in it, so it has to be either German, or German. Which one is it?
Take the middle one, German.
It's the middle one, German. So I asked you to be on the show. You didn't ask me, and the reason I wanted you to be on the show, I'll read your bio. Dr. Eric Schuetz, inventor of the recently patented Anglevator, the world's most efficient and versatile extraction instrument, has performed over 30,000 extractions, all under local anesthesia, and hasn't touched an elevator in over 12 years. Dr. E developed the Anglevator by modifying broken luxators over the last decade. The Anglevator combines all the best qualities: periotomes, luxators, proximators, elevator, all in one, like a Swiss Army knife oral surgery. And one of the reasons I wanted to do this is because when I lecture in like more, not the 20 richest countries like United States, Canada, Australia, and Western Europe, but when you're in more what I call real world countries, Africa, Asia, Latin America, they say that on Dental Town Online CE, it's too much CAD cam and lasers and all this Star Wars stuff that's never going to apply in Tanzania. But they say they have the most problems with oral surgery, and they need more help with oral surgery. And as far as cosmetic dentistry, it's more flippers and removables and partials. So I'm so glad, because there's 2 million dentists on earth, and we all do oral surgery, and you've added something to this. So talk about it. And by the way, you're gonna have to go through, because a lot of my homies aren't gonna know the difference between an elevator versus a periotomes, a luxator, a proximator. So go through the whole thing. Just give me your rant on oral surgery and why you invented this device.
Well, we all learned with elevators. They haven't changed for about 100 years. And it seems like the elevators tend to get smaller and smaller, but as we all know, a lot of times you can't get in between the tooth root and the bone. It's hard to get into the PDL. Well, many years ago, my father was a dentist who retired. He came to me and he gave me some of his old instruments. And he had this black-handled instrument. He said, "Hey, this is a luxator." I says, "Okay." He says, "It's really sharp. You go down between the root and the bone and the teeth just pop out." Kind of looked like an ice pick. So I says, "All right, I'll give it a try." I started using it, and he was right. It went down deep, and the teeth just popped out to the point where I didn't even use forceps half the time. But what happened was I used it so much that I broke the plastic handle inside. And I was like, I freaked out. All I could remember him saying was luxator. So I go to the dental catalog, this is probably back in 2001, 2002.
Okay, I wasn't even born then, but continue.
And I saw luxator, so the color was different, but the handle was the same. So I said, well, let me order these. So they came, and I started using them. And of course, we don't go and read the instructions till after we use them. It says don't elevate with them. Well, when you're down there deep, it's just natural. You want to twist your wrist and pop a tooth up. Well, all the blades were breaking. So I was like, man, that's $112. I'm not going to send this back. So I went into the little lab, took the green stones, white stones, started shaping the metal tips of these things, going back, using them. And after a while, they got to a shape where the metal was more supported and they all had angles. So I could go down deep and I was still able to elevate. Even the toughest horizontal impacted wisdom teeth, they weren't breaking. So I just started thinking about it. I says, wow, this is really something. Then years later, you see all these more like proximators, periotomes, which are designed to go deep into the PDL. But the problem with those instruments that I found is you can't elevate with them. And if you're down there 2, 3, 4, 5 millimeters into the PDL, you want to be able to luxate that tooth and pop it out. I didn't want to go change instruments 5 or 6 times. When I started working in Florida, we used to do Medicaid, and they used to do a lot of immediate dentures. I was pulling 30, 40, 50 teeth a day. So if you're pulling all of, let's say, 12 upper teeth, I didn't want to be switching between this elevator, this back and forth. It seemed like a big waste of time. So this instrument you can use it anywhere on any tooth. Root tips, wisdom teeth, even when you section teeth, it's just super efficient. You can actually, when you keep them sharp, you can cut. You can even lift the gingiva like a periosteal a little bit. And luxators are designed to loosen the teeth, but not to elevate.
Now,
So
if my homie's pulling out their iPhone and wants to see a picture of this, which website? You have two websites. You have GermedUSADental.com. Is that Ger for Germany?
yeah, German
Be,
medical. Yeah.
is that because you're German?
No. It's just a partner.
Oh, that's another. That's not your company.
Well, yeah, it is. That's a manufacturer. That's my manufacturing partner.
Okay, and that's www.ger for Germany, med for medical, usadental.com, and then the other website is anglevatorcecourse.com, Anglevator, VATOR, course.com. Which one of those websites would best be go to see what this instrument looks like?
Best on Germed USA. They both have pictures, but best on Germed USA Dental.
You can close that one. Oh, okay, okay. So German dental, and what would it be under? I see dental diagnostic, perio, implant, operative.
The extraction Anglevators.
I see. Would it be under surgical or forceps extraction? You said.
Yeah, it should be under there.
Under forceps extraction, atraumatic
Extraction kit. Look at the extraction kit.
extraction kit. I'll give it to my son. Rule number one is if you're 53 and you got a 20. How old are you, Ryan? 23. If you got a 23-year-old sitting next to you, just hand him the iPhone. That's
Exactly.
my best advice. So I wish you would do an online CE course on this for downtown. You know, we put up 350 online CE courses. They've been viewed over 600,000 times. And like I say, I don't feel nearly as good about transferring information from old dentists in America who've done 30,000 root canals to some young American kid who's done 300. I feel much better transferring knowledge from the 20 richest countries to the developing countries. And if you put an oral surgery course in there, because they're telling me in the flesh that they want more courses on oral surgery, flippers, and removable. And the Americans all want courses on, Star Wars, laser, CAD CAM, CBCD dentistry. So
I would definitely love to do that. Right now I'm putting together a course. I want to do it in the States because there's almost no places where people can do live extractions in the U.S. They usually go to Costa Rica, to the Caribbean. So right now I'm working on putting together one right here in Fort Lauderdale.
Well, we can help you put one on in Phoenix because, and if you're listening to this, here's the business. So due to the 1 million attorneys, you can't have a dentist going to another state and doing licensed dentistry and it's all that stuff. So it's just easier. Like in Arizona here, you go down to the Mexican border and you cross the border Yuma and there's hands-on implant cases, courses. Some people are going to Dominican Republic, Brazil, whatever. So there's a homeless shelter for vets in Phoenix, and every morning they have literally 100-yard line of vets wanting free dentistry. And the director of that, Chris Volchek, went to the state board and said, hey, if I put a hands-on course, can licensed dentists from another state come to my homeless shelter on American vets to do clinical dentistry, place implants, do extraction, whatever? How could the board say no to that? So the board said yes. So if you threw that course in Phoenix, in fact, we could do that just with local Phoenix dentists, but you could call Chris Volchek at the Cass Institute. Send me an email, howard@dentaltown.com. I'll put you in touch. But my God, in fact, that would be so cool to get a bunch of dentists say, today we're going to do the entire line of people standing out there wanting help. And you could just sit there and so anybody listening, call your state boards and give them the names of your state's homeless shelters, dental clinics for homeless shelters, and say, I mean, who cares where the dentist from? If he's a licensed dentist in good standing in America and he's coming over here to work on poor people, give him a temporary license. I mean, how do you say no to that?
Yeah, no, I would do it. As a matter of fact, I also have about 5 other forceps that I designed along, with my partner, Germed USA. Apically gripping, double serrations. There's not a forceps out there that can touch this. And I've looked at all the forceps. I had a very strange career that took me to over 16 different offices, working out of all kinds of different places, always messing with the instruments surgically, always did my own surgery. So we put together some really good forceps that in the past 6 months, we kind of put about 3-4 dozen out there to have the dentist try, and it's 100% coming back. Everybody loves the instrument. Once you start using one of these Anglevators, the reason it was called an Anglevator, because when I did the patent classification, it went down as an angled elevator. So that's how the Anglevator name came up. And right now it's being, the patent is being done in Europe and Canada. And it's for nobody has an angled tip. And it penetrates deeper, it cuts, it luxates, and it elevates.
And why just the patent in Europe and Canada? Why not the United States?
Oh, no, I have it already.
Oh, you have it in the United States.
Yeah, I had 1 year to file, and it means that nobody can make it in Canada, nobody can make it in Europe or import it. So, partner said they're going to copy it in China no matter what, but as long as you do,
Yeah,
Canada, yeah, in Europe you're fine. So.
I always it just irks me when these American manufacturers, they make their stuff in China. And then when China starts knocking it off and using all your idea and investment and then putting their own name on it, selling around the world, then they come back to the United States Justice Department and with my tax dollars of the Justice Department to go use our lawyers to go fight China. It's like, dude, I mean, God, I mean, we're bleeding 3 different ways on this deal. Why didn't you make it here? But you make it in China, yeah, they're gonna, of course they're gonna. I mean, what else would they do? They got 1,300,000,000 people. If you make your golf clubs and if you make your golf clubs in China, yeah, they're gonna use your whole setup and make them and sell them somewhere else. What is the what way you seem like you really like oral surgery?
I just, when I started working, Howard, I had an accident coming out of school. I didn't get my license for a year. I was a doctor without a license. So I was working construction. I was working at a bar. I was working as a...
What kind of accident?
I went off a mountain in a bus in West Virginia, my last semester of school at the University of Florida. It was all over the news, but I was all banged up, kind of screwed with my boards. So I graduated, but I had to go back and get my license a year later. So when I got my license, I didn't have a car. I had to sell a car to pay the rent. I had to walk a mile to work. So when I started working, I was too broke and too stupid to refer anything out. I just did everything and anything from day one. I was by myself my entire career. So I had to figure everything out myself. And back then, Medicaid in Florida, they used to pay. So somebody'd sit down, you'd pull 10, 15 teeth, do immediate denture. I've probably done thousands of those, And 20 years later, here I am, still going.
So you had a dad who was a dentist, so it didn't look like he was paying your way.
No, he retired before I got out. So I was left on my own.
Wow. But what doesn't kill you makes you stronger, and it made you a very strong, resilient dentist.
That's it.
So the thing I like about oral surgery is, American income, dentist income peaked in 2005 at like 119. And then it's been sliding every year. Now it's down to 174. When I look at the 9 specialties, I mean, endodontists and oral surgeons have 40% overhead. So when a young dentist comes out of school and says, I don't like endo, I don't like pulling teeth, I want to be a cosmetic dentist. And then their next question is, why is my overhead so high? And so what would you say to these people? I mean, they just sit there. How do they come out of dental school and say they don't like blood? I mean, they should have been an electrical engineer. What would you say to some kid who says, I don't like oral surgery?
I'd say you're missing out, because that's one of the biggest practice builders going. I mean, I can't tell you how many times people come in, they're in pain, they're hurting, and if you take that tooth out, easy, fast, simple, they love you. You got them for life. I can't tell you how many referrals I got as a general dentist for wisdom teeth extractions. Oh man, you pulled my uncle's tooth, you helped him out. And then if you do that for them, guess what happens when they need a crown? They come right back to you. So I believe you need to do a little bit of everything, because oral surgery, not only you're helping people, it's also you're learning. When you start laying open people's gums, the jaws, you learn a lot. You can see it, and then once you see it in 3D, it's a totally different thing.
And what do you think? Okay, you got out of school in 96, and now you're 46. What lessons do you think these kids come out of school in oral surgery that they're doing wrong, that they're not going to really realize till they've done 1,000 or 5,000 or 10,000 extractions? What do you think they're not seeing yet?
Well, the first thing I think it starts with is instruments. I mean, if I ask you to pound in a nail, if you have a carpenter that's pounded 1,000 nails and another guy's only pounded 2, but you give the carpenter a saw and you give the other guy a hammer, he's going to do a better job. So honestly, the elevators that we train with are not as efficient as some of these newer instruments. So first you got to get instruments that work well, and you just got to do it. You can't be scared. You just have to do it. And I think people use way too many instruments. Most of my instruments, what they do is they put one of my Anglevators up there, and then they put a forceps, but they don't open the forceps. 50% of my extractions, I use one instrument, go around, loosen the gum, pop the tooth out with my finger, and they're done. So there's only one instrument used. You don't have to bag. I see these people taking out 25 instruments. I'm like, what are you doing? You know, so I don't know if it stems from the teaching, but first the instruments. You're only as good as your instruments are. So that's the first step I would tell the young people, is get instruments that you know how to use and use them well. And try to use more universal instruments.
I was very lucky. I went to UMKC, class 87, and our oral surgery instructor was Matthias Horrigan. Rest in peace. Good old man, had like 7 kids. And when he got out of dental school, before he went to oral surgery school, he went to Korea. And when he was over there, they only issued a small and large elevator, a 150 and a 151. And he used to always have this gruff man, gregarious man, that says, you know, these are the only 4 things I had for 4 years, and I pulled a gazillion million teeth. And if you went and got any other if you got anything other than those 4 things, you better go to Brett Ferguson or Charlie White, the other oral surgeons, because Matt wasn't going to hear about it. And he was also just a tough guy where if you came and asked for help, he said he'd look at your time. And until you'd spent 30 minutes trying, he wouldn't help you. He's like, you know, just keep trying. Go back, keep trying. But he was a 4-instrument man and wouldn't help you until you spent a half hour learning yourself. So you basically just simple instruments, good instruments, get in there and do it.
I say the same thing. I can take one of my Anglevators and my 150, put those 2 in my pocket and walk around the world and pull every tooth on the planet. You don't need all these crazy instruments to
Okay, say that again. What instruments to pull every tooth on the planet?
One of my Anglevators, and then one of the 150s that I designed, which have thin beaks, but they come together. Put those 2 in my pocket, walk around the world and pull any tooth on the planet. You don't need all these fancy instruments. So I agree with what your professor said.
I agree.
Yeah, you have to know how to use your instruments.
Yeah, I agree. I almost only use a 150. I mean a small elevator.
Yeah.
I want to try yours, though. I can't wait to try yours.
Give yourself 10, 15 extractions to get used to it. But once you, like anywhere you use a 301, you use one of these. And you can, and it's just, you just take a rubber wheel and touch up the blades every now and then, and you'll be amazed.
Well, I want to see this on an online CE course. And like I say, it'd be so good of you to do that, because I never really care about helping a rich dentist in a rich country get 1% better. It's so cool when you're a revolution in Ethiopia or Sudan or, or Swaziland, or, you know what I mean? Then they always tell me in the flesh, more oral surgery. This is their dilemma. So I want to go to the reason that keeps them up at night. Here's why they don't want to try your instrument. Here's why they don't want to pull a tooth, because they're afraid the crown's going to snap off, and then they're going to have, a third of that thing root down there, and then they just want to go in the bathroom and cough up a blood clot. So walk through what you do when because that's what keeps them up at night. They're afraid they're going to break off, the root, and then they got to go in there and fish it out. And if not, then they got to pack this patient up and send them down the street to an oral surgeon. Maybe they're working evening hours, Saturdays. Talk about.
It was a lot of times. I'll snap a crown off on purpose, because I want to see the roots. Because of my instrument, I can get between the root and the bone very, very easily. If it's an upper, section it, pop the roots apart, and then you can just wiggle them out. If it's a lower, you can section and just pop them out. I've fished so many root tips with root canal files, I can't tell you. But when you crack a crown off, to me, I can see the bone structure, I can see the root. You can usually see whatever undercut that root is in. And then you work this instrument in, and you'll be able to wiggle them out. Actually, you can go to YouTube Anglevator, and there's about 45 videos that I have up there of using this instrument and these forceps. And I try to put more up every week as I get
Have you
videos.
posted them all on Dentaltown?
No, I've never
See,
posted.
the problem with YouTube is there's 80 gazillion million. I just read the other day that if you're born the same day Jesus was and watch YouTube 24 hours a day for 2,000 years, that's how many videos get uploaded every year on YouTube. But so when you go to YouTube, when it
Yeah,
says share and it gives you the link,
I
so
can
if you're
shoot them.
so you're emailing the link to someone and you click that and you open YouTube.
Uh,
Well, it's also on the share. There's called embed. And then there's a code for that. So then you go on Dentaltown and you could start a thread about your technique. And then when you go to post, there's a little YouTube icon. You click that, you drop the embed code, and then it drops the whole YouTube video in the thread. So if you got 23 YouTube videos, you could literally start a thread under oral surgery and
okay.
post those 23 individual videos. And then Dentaltown's got what, 215,000 dentists? And every dentist who's done that says their YouTube channel exploded. Same thing with the podcast. They use Dentaltown to market their YouTube video channel. And the people that have put their podcasts on Dentaltown say that their iTunes downloads exploded because these dentists are all seeing it on the Dentaltown app, on their iPhone, Samsung, whatever.
I'll definitely do that. It's done. I mean, yeah, I have right now about 46 videos.
Yeah.
Live real time. Okay, and I'll figure it. If I can't do it, I'll give my 24-year-old daughter to figure it out for me.
Yeah, have her do that. And if you're making an online CE course, my God, you've already got all the content.
Okay, yeah, I have tons of content. There's a World CE Alliance starting. Have you heard of that?
No.
They had contacted me and I sent off some content and they're starting to blast a worldwide CE, and a lot of it's focusing on some countries like you said, people who need more.
Is it here? Find it, Ryan. It's World.
World Continuing Education Alliance or something like that.
Is it for dental only or medical or?
They're going to launch dental right now. I think they have vision, veterinary. They're going to do the whole scope. And honestly, I can't tell you how they contacted me, but they contacted me, and I have a whole PowerPoint that I sent off, and they're going to start, I guess, this summer marketing it around.
Well, yeah, forward me that email, howard@dentaltown.com. The World Continuing Education Alliance, WCEA.education. Is that what you're talking about?
Yep, that's it right there.
Right on. How much of root tips breaking off do you think does a novice do because they weren't luxating it properly before they started applying force? How much of that do you think a young kid coming out of school is breaking off a lot more root tips than an old guy like us?
Yeah, because I think that they're using elevators and they're pushing most of the force on the crown. If you can get down onto the root and you push all that force on the root, you're not going to snap that crown off as much. But again, it goes back to the instruments. If you can't get down onto that root surface and you're pushing on the crown, it's going to snap off. So if you get down 2, 3, 4 millimeters and you can push on that root, you can move the whole root. And if you keep working it apically, I tell people, listen, a root is harder than bone. Stainless steel is harder than both. When you start working that into the PDL, the bone's going to expand, and then that metal is going to displace that root. It's going to get loose. You just got to have patience and know exactly, the best places to penetrate the PDL.
So, does it now? Let's switch from the edentulous mouth, to wisdom teeth.
Okay. Wisdom teeth, I use the same instrument. I take those out. I've done tens of thousands of wisdom teeth. Whether they're fully impacted, if they're mesially tilted, I just take off the mesial part of the tooth. I work my instrument towards mesial buccal. I can usually get underneath and stand them up. Now, if there's a little bone over the back side of the tooth, sometimes you cut like a little wedge and it just pops right up. The easiest teeth to pull in the mouth, are 1 in 16.
Right. I know.
That's a 2-second thing.
I think the dental assistant should be allowed to pull 1 in 16 and do all incisor endo. I don't know why you need to be a doctor to do a root canal on an incisor.
Like 3 minutes, right?
So I'm going to get back to specifics. Because what I'm trying to coach is these young kids that walk out of school and their worst enemy lives between their ears, and they just made some flippant statement like, I don't like extractions. I don't do endo. I don't do extractions. And then when I pin them down, like, extractions, what's keeping you up at night? It's bringing on fruit tips. The second thing, when we talk to wisdom teeth, we both agree 1 in 16 your assistant can do. But on the lower two wisdom teeth, they're always freaked out about a paresthesia. Talk about that. Why does that not freak you out?
I don't know. I've never had a problem. You look at your x-rays. If you think it's wrapped around the nerve, of course, don't do something stupid, but I've never had, knock on wood here, any kind of paresthesia. Distally inclined, lower third molars are harder than the mesially inclined. I think we all know that.
I don't think, I think that's a big assumption. You're talking to well over 10,000 dentists, so they all don't know. Talk about the difference between mesial and distal incline.
Well, if your lower tooth is tilted mesially toward the second molar, you can usually get underneath it and stand it right up. Sometimes when they're going distally, you can pop them up and they go back into the cheek. So sometimes it's hard to retrieve them. You just have to be a little more careful. That's all I mean by that. And sometimes when they're going distally, there's some distal bone at the CEJ, between the crown and the root that kind of locks them in. It makes people get a little scared. Oh, I'm scared to take a little bone there away, but sometimes you have to. But with these Anglevators, even when you have to drill a little bone, you don't have to take as much as you do for these elevators. You just would do a little slot, and you can work it in there, and you can push the bone out of the way as you elevate the tooth.
We should have a picture of that instrument. You should send Ryan, email Ryan an image of this instrument. So
yeah, it's kind of hard to talk about something when you can't show it. But yeah, I'll do that. And if you want to schedule something in Phoenix, I'll come out I'll send a bunch of instruments out, and we can line people up and just take care of people all day.
God, that'd be a blast. To set up a CE course at that place.
And I'll get all the instruments also.
And when we start, we'll have our first beer when the line is halfway done. And then when the line is all the way done, we'll have our second beer. How's that sound?
That sounds good to me.
But that would be an amazing feeling. I feel so sorry for these vets. They went over there and got all beat up, and then they come back to America. And what are the two benefits they don't get? They get health insurance, but it doesn't include dental or psychiatric. How insane is that?
Yeah, I know. It's pretty sad. It's pretty sad. Going back to the students, I'm down here by Nova Dental Schools here, and I had a girl come one time, and she shadowed me, and I asked her, I go, how many teeth do you pull before you graduate? And she said about 10. I said, what? 10 teeth before you graduate? No wonder they're coming out scared to death. They don't know what to do. They have no experience in some of these schools. I don't know if that's true around the nation, but that was very shocking to hear. And so I think that contributes to a lot of these people's fear, a lot of these young dentists' fears.
Well, I was lucky in dental school because every time there was a spring break and a fall break and the dental school was closed for a week, they offered a part-time job to work the pain clinic in the oral surgery department. It's downtown Kansas City. And I always worked that job. And there was a girl there a year older than me, Susan Wires. And my God, we pulled that 1 week. I mean, you would pull 50 to 100 teeth every time in that 1 week. I mean, which is big numbers for a dental school.
Yeah.
And I always love that. I think part of oral surgery is it's the lowest cost, it's instant gratification, and it's done. I want to talk to you another more things keeping them up. I'm just reviewing questions I see all the time on Dental Town. These young dentists that get out there, you come in and you're swollen, and they don't know if they should put you on Pen VK or Keflex for 48 hours or 72 hours, then pull the tooth, or talk about a toothache. When do you just go in and pull it, and when do you go in there and say, nah, we need to put you on antibiotics first?
Sometimes if the person's so swollen they can't open or can't move, or if you have limited access, I would put them on antibiotics. Now with Septicaine, you're able to get teeth more numb a little easier than just straight lidocaine. That's a case-by-case call. Sometimes I'll pull it, drain it, or sometimes if they can't open, I can't get to it. If they're scared, their psychological state, then I'll put them on. I use amoxicillin 4 times a day. If they come in they got a softball this big, I use amoxicillin with Flagyl, combine them, it sucks it down in a couple of days, then bring them back. But I've done it both ways, so I can't. It's hard to say.
What percent of the time do you do the extraction at the toothache versus delay them with antibiotics?
Probably I'll take him out 80% of the time of that day.
80% of the time?
Yeah, because sometimes you give the antibiotic, they never see him again.
I shouldn't say this, but I've noticed this in my own practice. Some oral surgeons in my backyard, they say, the best way to manage an infection is get the tooth out and drain it along with antibiotics. So some do antibiotics before, but I've noticed over the last 30 years, more and more oral surgeons saying, actually removing the tooth is one of the best ways to start managing this infection. Let's get the source of the infection out. So I've seen it where 30 years ago it was always antibiotics first, to now a lot of oral surgeons use an extraction as part of the way to manage that infection.
Yeah, I agree. It's like I tell people, hey, if you have a infected splinter in your arm, I'm not going to leave it there. You're going to pull it right out. So why would you leave an infected tooth in your mouth? If you can get it numb and handle it, take it out.
And as far as paresthesias, I've never had a paresthesia from pulling a wisdom. I've had two paresthesias in my life. One was 6 months, one was a year, and they were both from a mandibular block hitting the lingual nerve to the tongue. So twice in 29 years, I've had someone come back and say, my tongue's still numb. But anyway,
Yep.
so I just figured, go
Yeah,
ahead.
when I had the lady had such a bad infection on a number 20 root canal that it impinged on the mental frame, and it lasted 2-3 weeks and then went away.
Yeah, from the pressure. So
Yeah.
so what? Talk more about chair side time management. You say get it done once the bell rings. What do you mean by that?
Well, I don't know if you have any. A lot of dentists are quitting early because of pain. You know that a lot of people have from carpal tunnel to neck, shoulder, back, elbows, all kinds of pain. So the longer that you are doing a procedure, the harder more wear and tear on your body it is. So if you can go in and get something done in 30 seconds, why would you sit there and fiddle for 5-6 minutes? As you know, if you're bent over for 5-6 minutes, it's a lot harder than a minute. So for me, like I said, I was doing so many immediate, so I was doing 40-50 extractions a day on top of general dentistry. So say if I was doing taking out 12 teeth, I wasn't going to change my instrument 10 or 12 times. That's a waste of time. That's not efficient. It's all about ergonomics, which the handles on these Anglevators are that Swedish design, which gives you a lot more torque with a lot less effort. So for me, like I said, when I started, I was so broke. So I was, hey, if I can pull a tooth in 1 minute, I get the same amount of money if it takes me 20 minutes. So I can pull 10 of them in 20 minutes. So that's kind of how I started. And I wanted the least amount of movements because they call it prolonged static positioning is what causes the musculoskeletal disorders later on in our careers. I don't know if you're suffering from any of that, but I got some issues.
Yeah, my neck is jacked, and I went to a chiropractor my whole life, but then my buddies Tom Manor and his wife Sharon turned me on to hot Bikram yoga about when I turned 50, and that's really been a game changer for me. But yeah, you got to look direct. You can't be leaning your head over. You can't be in all these weird positions. And I think if you're listening to this, you need to go because you don't get it because you don't see yourself. You need to go tell your office manager, your front desk, because your assistant's in there with you. But tell the rest of your staff, like when your hygienist comes to get you for a hygiene check, tell her to snap a picture of you and then text it to you so you can see what your body's doing. Because when I told my staff that, they'd send me these pictures like I just look at it like, what the hell am I thinking? And you need to sit up straight, use the mirror, just.
But sometimes you just got to bend over and look. You don't have a choice sometimes.
So I want to ask you another ergonomic question. You and I know that back in the day, all the old oral surgeons did everything standing up, and starting to pull teeth sitting down was a relatively new thing. So I ask you, when you pull teeth, you stand or sit?
I stand.
So
I
do
stand
I.
everything. 90. I stand for crowns. I stand for almost everything, unless I'm doing some like apicos or something up top. But you got to have the right chair for that. I'm 6'2", so some of these chairs don't come up very high. And when I had my own practice for over a decade, I had the old chairs that were thin back and come up real high, and you can get them right there on your lap. So I prefer to stand for 99% of everything.
Even a crown and a filling?
Yeah, depending on where they are, yeah. You can listen, if you're prepping a lower molar, you can see the lingual of 30 and 31 much easier by standing than sitting. You can, that's just for me. I can move around. I actually got rid of all my seating chairs. I had one chair for 4 ops because I almost never used it. I would go room to room and just stand. Unless I was
And you stand for a root canal too for an hour. You stand there doing a root canal.
take an hour to do a root canal. No, I'll sit. I'll sit for the upper root canals and I'll stand for the lowers.
Huh. I stand for all oral surgery, and I always wonder why. And I just figure maybe it's psychological. I don't know what it is, but I just.
I think you can see better, and I think you have more leverage. You feel, you're standing. You feel more secure. Yeah, I stand. I think you get more leverage. I think you're more secure with your, standing with your feet. I think you see better also.
And I wonder which one's better for your neck and shoulders and back over the time, standing or sitting.
I think you should fluctuate between both, but if the chair comes up high enough, I think you'll have less back problems by standing.
Yeah. So you mentioned Septicane. So did you switch Lido to Septo universally, or talk about that?
I'll block with lidocaine, and then maybe I'll do a PDL with Septo, and on the uppers you can use Septicane.
So why don't you like to use Septicane for blocks?
Well, you're not supposed to because of potential paresthesia, which I have used it on blocks before, and I've never had a problem. But I think they put that in the literature, maybe 10 years ago or something?
Yeah, I think it was a long time ago, and I think it's been disproven. I've been trying to get Stanley Melamed to come on this show forever, and he always tells me he's too busy. But that'd be a good question for Stanley to get on the show. But yeah.
I use it for blocks. I have. I'm not saying I don't.